All right, let's discuss the common problems associated with pregnancy today. So first of all is morning sickness. So patient will come with a chief complaint of nausea and vomiting in the morning especially, and this basically occurs during the first trimester of pregnancy, right? Now let's come to the management. So first of all, we will counsel the patient and reassurance is important. Then I will write vitamin B6, that is 10 to 25 milligram TDS, right? I can also write doxylamine if needed. So this is the first line treatment of morning sickness, right? And if the patient doesn't recover with this, then I can write metoclopramide, which comes under the name of mixolone, right? That is 10 milligram orally. I can also write promethazine. I can write chlorperazine, right? And the third line treatment should be ondansetron. That is, I can write injection onset in Pladix or normal saline, right? Then I will advise the patient to eat small and frequent meals, right? And I will advise to avoid fatty, spicy, and strong smelling foods. Now let's discuss hyperemesis gravidarum. So basically, if the nausea and vomiting of the patient is persistent and severe, then it gets converted to hyperemesis gravidarum, right? This patient will be unable to tolerate foods or fluids. There will be dehydration. Patient will experience weight loss, dizziness, ketonuria, right? Now let's discuss the management of hyperemesis gravidarum. First of all, we will admit the patient if she is severe. Then I will write injection on set in 100 ml normal saline or ringer lactate, right? And I will monitor urine output and ketones, right? Then upon discharge, I will write metoclopramide, which comes under the name of tabmixolone 10 milligram TDS for 10 days. Plus, I can also write iron supplements, folic acid, or vitamin B6, right? Now, the third one, anemia. So, patient will come with a chief complaint of fatigue, weakness, paler appearance, dizziness, shortness of breath. Plus, she might experience palpitation also, right? Let's discuss the management now. So first of all, I will investigate the patient, that is check HB, and will treat the underlying cause. Like the most common one is iron deficiency anemia in pregnancy. So I will write iron supplements plus I will advise iron-rich diets, right? Plus there can be physiological anemia, which is quite normal in pregnancy, right? That is dilutional. And if there is folic acid deficiency, then I will write folic acid supplements, right? There can be, which is a little bit rare, but there can be vitamin B12 deficiency. So I will write vitamin B12 then, right? And uh, if still the patient doesn't recover, then I will advise the patient to go for blood transfusion if the case is severe, as I said earlier, right? Now let's discuss hypertensive disorders in pregnancy. So it can be chronic hypertension, gestational hypertension, eclampsia, right? So first discussing gestational hypertension. So patient will have complaint of BP, that is above 140 by 90 after 20th week of pregnancy, and she may be asymptomatic or may be associated with a headache, right? Now let's come to the management. So first of all, we will monitor the blood pressure regularly to detect worsening hypertension, right? Then we will monitor fetal well-being through fetal moment count, and we can also go for ultrasound when indicated, right? I can also write antihypertensive medication I can put the patient on labetalol, extended release nifedipine, right? Or I can give methyl dopa also. Then I can perform urine protein testing to detect progression to preeclampsia, right? Now let's discuss preeclampsia. So patient will have severe headache, blurred vision, facial and hand swelling, epigastric pain, high blood pressure, and most importantly, proteinuria, right? That is, if the gestational hypertension is associated with proteinuria, so obviously it becomes preeclampsia, right? Now, how we will manage the patient? First of all, we'll admit the patient to the hospital. Then we will control blood pressure of the patient with these medications. We will give magnesium sulfate. That is prophylactic because it is basically given in eclampsia. Then we will monitor mother and fetus closely, right? Then I can plan timely delivery of the patient also, right? Now let's discuss eclampsia. So eclampsia is basically preeclampsia with seizures, right? So patient will have complaint of convulsions. This is the most important one. Severe headache, blurred vision plus flashing light, swelling of the face, hands, feet, nausea, vomiting, and in some cases loss of consciousness also, right? Now we'll discuss management on the other page. Now let's come to the management of eclampsia. So first of all, I will stabilize the patient. That is, I will apply ABC protocol. That is, maintain airway, breathing, then circulation. Then we'll lie the patient on left lateral position, right? Then I will administer oxygen and secure IV access. Then we will maintain seizures by giving magnesium sulfate. But remember, if magnesium toxicity occurs, then we will give 10 ml of 10% calcium gluconate IV as an antidote, right? Then we will control blood pressure of the patient by giving labetalol, hydralazine, or I can also give nifedipine, right? Then I will monitor the mother and the baby, right? And once the mother is stabilized, then delivery is the definitive treatment, right? Regardless of gestational age, depending on maternal and fraternal condition, right? Gestational diabetes now. So it is quite common but manageable and is often asymptomatic, or patient might come with a chief complaint of thirst or frequent urination. Now let's come to the management. So I will advise proper diet, exercise, glucose monitoring is important, right? And in some cases, I can also prescribe insulin if needed, right? Now let's come to UTI in pregnancy. So first of all, patient will come with a chief complaint of burning sensation during urination, frequent urination, right? She will have urgency, lower abdominal pain, fever in some severe cases, right? Now let's come to the management. So first of all, I will write antibiotics. Remember to choose the antibiotics that are safe in pregnancy. That is cephaloxime 500 milligram orally. It is every 6 to 8 hours for at least 5 to 7 days, right? I can also write amoxicillin, clavulanate, nitrofurantoin, right? Then encourage adequate fluid intake, right? That is hydration. I can also write symptomatic care, that is paracetamol in case of fever or pain, because paracetamol is safe in pregnancy. And then I will put the patient on follow-up